Welcome to this Step 3 clinical skills review on the patient who arrives short of breath in the emergency department. This video is brought to you by Roadmap to Residency. The goal here is not to reteach all of pulmonary and cardiac medicine. Instead, we will break down the exact question patterns the boards use for breathlessness and give you strategies to pick the right answer quickly and confidently. We will cover rapid assessment and oxygen therapy, telling chronic obstructive pulmonary disease apart from heart failure, risk stratifying for pulmonary embolism, and deciding between non-invasive ventilation and a breathing tube. Make sure you have reviewed the pulmonary and cardiology sections of your primary review book and your question bank before or alongside this video. Here is what we are going to cover today. First, we will recognize the high-yield question stems for the patient who is short of breath in the emergency department. Second, we will apply the strategy that splits chronic obstructive pulmonary disease from heart failure, and we will work through pulmonary embolism risk scoring with the Wells score and the rule-out criteria. Third, we will master the next best step format for oxygen targets and the decision between non-invasive ventilation and intubation. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach so you can move fast on exam day. Our first strategy is the chronic lung versus heart split. When a question opens with a breathless patient, immediately ask yourself, does this stem point to the lungs or to the heart? For chronic obstructive pulmonary disease, look for a long smoking history, a barrel chest, slow worsening over days with more sputum, wheezing, a prolonged expiratory phase, and hyperinflation with flattened diaphragms on the chest film. For heart failure, look for breathlessness lying flat, waking at night gasping for air, leg swelling, crackles at the lung bases, a third heart sound, an enlarged heart with congestion on the film, and a high brain natriuretic peptide level. The boards love to plant one or two of these clues early in the stem, so train yourself to spot them in the first two sentences. Strategy 2 is pulmonary embolism, risk stratification, and the boards test this through two tools. The first is the Wells score, which estimates your probability before any testing. Watch the stem for signs of a leg clot, a heart rate over 100, recent surgery or bed rest, a prior clot, blood in the sputum, cancer, and the clinician judging embolism the most likely diagnosis. The second tool is the rule-out criteria, and here is the trap the exam loves. Those criteria only apply when your clinical suspicion is already low. When the patient is low risk and meets every single criterion, including age under 50, normal heart rate, normal oxygen level, and no prior clot, you can stop without further testing. But if even one item is missed, you cannot rule out embolism on the criteria alone, and the patient needs a sensitive blood test or imaging. Knowing which tool to reach for and when is the whole game. Now let us go through high-yield stem recognition for the three big causes of breathlessness. For chronic obstructive pulmonary disease, the classic stem is an older smoker with gradual worsening over days, more cough and sputum, wheezing, a prolonged expiratory phase, and hyperinflation on the film, often with a high carbon dioxide on the blood gas. That stem rewards controlled oxygen and inhaled bronchodilators. For heart failure, look for the patient who is breathless lying flat, wakes at night gasping, has leg swelling, crackles, and a third heart sound with congestion on the film and a high brain natriuretic peptide. That stem rewards diuresis and non-invasive ventilation. For pulmonary embolism, look for sudden breathlessness, sharp chest pain that worsens with breathing, a fast heart rate, low oxygen with a clear chest film, and a recent surgery, long flight, or leg clot. That stem rewards risk scoring first, then the right test. These patterns repeat over and over, on practice questions and on the real exam. Let us work through our first practice question. A 68-year-old man with a long smoking history arrives with 3 days of worsening breathlessness, cough, and yellow sputum. He is alert. The respiratory rate is 28, and the oxygen saturation is 86% on room air. On exam, he is wheezing with a prolonged expiratory phase. The question asks for the most appropriate next step. Notice the slow course, the smoking history, and the wheezing. Look at the answer choices and decide how much oxygen you would give and whether this alert, stable patient needs a breathing tube right now. We will walk through the answer on the next slide. Let us break this down step by step. Spot the pattern first. An older smoker, gradual worsening, wheezing, a prolonged expiratory phase, and low oxygen. This is a chronic obstructive pulmonary disease exacerbation, And the slow course plus the smoking history are the giveaways. Now apply the rule. Give controlled oxygen and aim for a target saturation of 88 to 92%, because flooding this patient with oxygen can worsen carbon dioxide retention. Then add inhaled bronchodilators, steroids, and antibiotics. Now eliminate the wrong answers. High-flow oxygen chasing 100% risks carbon dioxide retention, so that is wrong. Immediate intubation is too aggressive for an alert, stable patient who has not had a chance to respond to treatment. Withholding oxygen from a hypoxic patient is dangerous and never correct. The answer is controlled oxygen plus bronchodilators. The single most important lesson: never withhold oxygen, but in the chronic lung patient, aim for that lower target. Here is our second practice question. A 34-year-old woman presents with sudden breathlessness and sharp chest pain that gets worse when she breathes in. She returned from a long flight yesterday. Her heart rate is 110. Her oxygen saturation is 91%, and her chest film is clear. There is no leg swelling and no blood in the sputum. The stem tells you clinical suspicion is low. The question asks for the most appropriate next step. Pay close attention to that phrase, clinical suspicion is low, because it is doing a lot of work here. Look at the choices and decide whether you should reach for the rule-out criteria, jump straight to imaging, start treatment blindly, or simply send her home. We will work through it next. Let us work through this answer. Read the question carefully, because the key phrase is that clinical suspicion is low. That single phrase is your instruction to apply the rule-out criteria before you order any imaging. Now here is why the rule-out criteria win. When suspicion is already low, those criteria let you safely avoid testing only if the patient meets every single item. In this stem, her heart rate is over 100, so she fails the criteria. Failing the criteria does not mean she gets a scan reflexively. It means she now needs a sensitive blood test or appropriate imaging as the next step. Look at why the other choices are wrong. Ordering the scan immediately skips the step the question is testing. Starting full anticoagulation without any testing is premature and unsafe. Reassuring and discharging her without ever checking the criteria is the most dangerous choice of all. The answer is to apply the rule-out criteria. The lesson: match the tool to the pretest probability the stem hands you. Let us review rapid assessment and oxygen therapy because the first 60 seconds win these questions. Always start with airway, breathing, and circulation. Put the patient on a monitor, check the oxygen saturation, and get access. On the boards, the very first action for a hypoxic patient is almost always to give oxygen and sit the patient upright, before any imaging or blood work. Now choosing the oxygen target. For most breathless patients, aim for a saturation of 94 to 98%. But for patients at risk of carbon dioxide retention, such as those with chronic obstructive pulmonary disease, aim for a lower range of 88 to 92%. Here is the high-yield trap. The boards love to punish over-oxygenation in the chronic lung patient. So the rule is simple. Never withhold oxygen from someone who is hypoxic, but choose your target based on whether the patient retains carbon dioxide. Here is our third practice question, and this one is about breathing support. A 72-year-old woman with a history of heart failure arrives severely breathless and unable to lie flat. Her respiratory rate is 32, her oxygen saturation is 88%, and she is using her neck muscles to breathe. Importantly, she is awake and following commands. On exam, she has crackles to the mid-lung fields. The question asks for the most appropriate next step in breathing support. The two phrases that should jump out at you are awake and following commands, and the picture of fluid in the lungs from heart failure. Look at the choices and decide whether she needs non-invasive ventilation, an immediate breathing tube, a small amount of oxygen, or simply observation. We will walk through it next. Let us break down this answer. The pattern here is severe heart failure with breathlessness, low oxygen, and accessory muscle use, but the patient is awake and protecting her own airway. That combination is the ideal setting for non-invasive, positive pressure ventilation. It reduces the work of breathing, helps push the fluid back, and very often prevents the need for a breathing tube. Now the key distinction: immediate intubation is reserved for the patient who cannot protect the airway, is losing consciousness, or has already failed a trial of non-invasive support. This patient is awake and following commands, so she has not earned a tube yet. Low-flow oxygen by nasal cannula alone is not enough for this degree of distress. Observation with no support is unsafe. The answer is non-invasive, positive pressure ventilation. The lesson: an awake, cooperative patient in respiratory distress is the classic non-invasive ventilation answer. Here is a critical test-taking pearl about when to use non-invasive ventilation and when to reach for a breathing tube. Non-invasive ventilation is the favored answer for an awake, cooperative patient with fluid in the lungs from heart failure or with a chronic obstructive pulmonary disease exacerbation. The patient must be able to protect the airway and follow commands. When that is true, non-invasive ventilation buys time, lowers the work of breathing, and often avoids a tube entirely. Now the hard stops, the situations that should push you to intubate. Choose intubation when the patient cannot protect the airway, is unconscious or rapidly tiring, has copious secretions or vomiting, or has already failed a trial of non-invasive ventilation. The classic exam trigger is a falling level of consciousness in a breathless patient. The moment the stem tells you the patient is becoming drowsy, confused, or obtunded, that is your cue to secure the airway. Commit this contrast to memory, because the boards test it constantly. That wraps up our review of test-taking strategies for the patient who is short of breath in the emergency department. Remember the core moves: assess airway, breathing, and circulation first. Give oxygen to the right target. Split chronic obstructive pulmonary disease from heart failure using the buzzwords in the STEM. Risk stratify for pulmonary embolism before you image. And choose non-invasive ventilation for the awake patient while reserving a breathing tube for the patient who cannot protect the airway. Review the pulmonary and cardiology chapters in your primary review book and your question bank, and drill these patterns until they are automatic. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.